Thank you for joining us for Talking Sleep, a podcast of the American Academy of Sleep Medicine. I'm your host, Dr. Seema Khosla, Medical Director of the North Dakota Center for Sleep in Fargo. Today's episode is sponsored by Takeda. Dr. Lee Neilson is an assistant professor of neurology at the University of Iowa and a staff neurologist at the Iowa City VA. He specializes in all aspects of movement disorders. He has been examining how obstructive sleep apnea may be a modifiable risk factor for Parkinson's disease. He examined records from 13 million patients within the VA system and analyzed whether or not obstructive sleep apnea was associated with a higher risk of neurodegenerative disorders and if treating the sleep apnea might help delay the onset of dementia. He is here today to walk us through this research. Welcome. We're happy to have you here today.
Well, thank you for inviting me here.
So this seems like a gigantic undertaking. So walk me through your thought process, your hypothesis, and how you set about designing this research.
So we came at this from the perspective, we recognize that Parkinson's disease is this heterogeneous disorder that currently lacks a definitive disease-modifying treatment. But we do believe that there are some things out there that we can identify and maybe prescribe to our patients now that might make a meaningful difference in their disease trajectory. And the thought behind that is that this is a really fast-growing neurological disorder. In fact, the rates are picking up, even after you account for the fact that the population is aging globally. Genetics plays a small part, maybe 5 to 15% of cases have a genetic component, but most of those are risk alleles, not necessarily these monogenic kind of causes. And my guess is that the genes are a fairly stable trait. And so the implication then is that it's got to be something external, something environmental that is contributing to this accelerated growth.
So is it really accelerated growth, or is it that we're better at diagnosing it?
I think it's a little bit of both. So we are having more expertise out there. We have more consensus on how to make the diagnosis, more experts that are confident in making the diagnosis. So that's going to be one part of it for sure. But we can only diagnose it so early. We still have to wait till that tremor comes out or they really start to walk a little bit differently. And so I do think that there's this other external factor. And so the second implication then is that if there is something else going on, driving this, then maybe we can do something to remediate that.
So tell me about your research. Was this a retrospective analysis? Was it prospective?
We would actually just describe this as a electronic health record-based cohort study.
Okay.
And so what that means is that the data that is being collected in the Department of Veteran Affairs is being done in a prospective manner. So every day a veteran comes in, they get their care, those ICD codes, those CPT codes, all of those things are being updated continuously and longitudinally. What we did is we went back in time to a point earlier in their medical record to identify people, in this case with and without obstructive sleep apnea, and then we could follow them forward to see what are those differential rates and outcomes. So when I'd asked statisticians about this, because I originally called this a retrospective study, they're like, well, no, it's kind of it's prospective, but we already have the data. And so we settled on this EHR-based cohort study to kind of capture that complexity.
Okay, that's fair. So tell us, what did you find?
So the number one takeaway was that veterans with sleep apnea had this greater cumulative incidence of Parkinson's compared to the group without sleep apnea. And that started as soon as 2 years after of following them up. And so if you put some numbers on it, their risk is about doubled. So about a 92% increase in PD in that group.
Oh, wow.
And the second thing that we showed is to try to stratify by sleep apnea severity. So we looked at those with mild sleep apnea, and then we looked at those with more severe sleep apnea, which we can define that a little bit later, but loosely kind of an AHI less than 15 and an AHI greater than 30. And so those who had a more severe sleep apnea had a much higher rate or much higher risk of developing Parkinson's. And then the third thing, which was really the most exciting thing for us, is that those who were prescribed CPAP, and we defined this as getting this device within the first 2 years of being told they had sleep apnea, those people, they had a much lower risk of developing Parkinson's. In fact, you could cut their risk by about 30%.
Oh, wow, that's huge. And just to clarify, when you said AHI under 15, you mean 5 to 15, right? You're not including the negatives.
That's right, 5 to 15.
Okay. So that's a pretty impressive change then.
Yeah, these are relative effects, but yeah, I think that is meaningful on a population level because there's a lot of people with sleep apnea.
Yeah.
And if you apply that to that large group, that could make a difference.
And so how did you figure out that someone had sleep apnea? Did everyone have a test? Like, is that how you figured it out?
No, so we did a couple of things.
Okay.
The first thing we did was just say there's an ICD-10 code for sleep apnea, and if you've got that, that means you must have sleep apnea, and if you don't have that, that must mean you do not have sleep apnea. We wanted to make sure, though, that that code was meaningful. So we did have a couple of sleep-trained investigators on our team. They randomly, they looked at 500 random medical records that both had that code and did not had that code, and could just dive into what are the clinicians writing about. Did they reference a PSG? What was their impression? Did they have sleep apnea? Or were they actively treating it or counseling them on it? And so it turns out that well over 90% of the time, if that code was in place, they truly had sleep apnea. And that was consistent with kind of other studies outside of the VA. There's a pretty high concordance rate. So you sleep people do a good job. And so people like me appreciate that.
I love that. So the VA usually uses the 3% hypopnea rule, right? Is that what you saw in the study, or was it 4%?
So in our definition, we didn't look at that at all. So I actually couldn't tell you how many people were following the 3% rule or the 4% rule. Getting access to the hard numbers from the PSG was something that was challenging to do, overly laborious to curate, and so that's a little bit of an unknown, and would be interesting to look at.
That's fair, but we're just taking it that they had the ICD code, they had something in the clinical verbiage, and we feel confident that this cohort has sleep apnea. Is that fair?
I feel confident. I leave it up to you guys to decide if you trust me.
And so what about the other side then? How did you figure out if somebody had Parkinson?
Yeah, this is actually a trickier problem. So there was a really nice paper actually by Sam Goldman and his team out in San Francisco that looked at the same approach. And this was actually in the VA system, so directly relevant to our work. And they said, hey, there is an ICD code for Parkinson's disease, G20. And if somebody has that code, the results are not good.
Really? Okay.
You're actually more likely to not have Parkinson's than to be accurately coded as PD. It was about 46%. And so we knew right off the bat we needed to be a little crafty.
Yeah.
But we know a lot about Parkinson's disease, and so we tried to put all those different things together to kind of build our definition. So one, we started with that code. We figured it's unlikely that somebody with Parkinson's is not going to have that in their chart. The second thing is we wanted to look at the persistence of that code over time.
Okay.
We wanted to look at their Parkinson's medications. So were they on carbidopa, levodopa? Did that prescription carry forward in time with the implication that those refills might suggest some treatment response. And so you add all of these things together, and we can be much more confident in our ascertainment of PD. And then we took a second step as well. And we said, hey, neurologists, those are the people that have the real training and expertise in Parkinson's disease. They're probably better than an emergency room physician. They're probably better even than a geriatrician. And so we were able to kind of secondarily look at another cohort and say, okay, if they only saw a neurologist and they met all these other criterias, and over the course of the next 2 years, that neurologist still said they really do have Parkinson's, now we're looking at almost 90% accuracy.
Oh,
And
wow.
this had all been done, manually, going through the records and being certain. So that's probably as good as
Okay.
we're gonna get, because that's as good as I am in real life. I probably can't do any better than that.
So was it PD alone, or did you look at other disorders like Alzheimer's?
No, just Parkinson's. So
Mm.
this is that other 10% certainly could be contaminated by a drug-induced Parkinsonism or a Lewy body dementia, maybe even some Alzheimer's, but we were trying to have as pure of an outcome as possible.
Okay. So then what was the end result then? Did CPAP have a modifying effect? You said it sounds like you said that it has a little effect anyway.
Yeah, exactly. So we were able to show CPAP did have a modifying effect. So about a 30% risk reduction. And again, that's in people who got CPAP within the first 2 years of uh, having that sleep apnea code.
So is it that they never develop it or that you delay the onset?
So in our study, which the average time we were able to follow people was about 5 years, maybe 6 years.
Okay.
What we showed is that this was ability to prevent a case of PD from arising. Now, if we were to follow even farther,
Yeah.
maybe it turns out that these people are getting the disease, but it's 3, 4, 5 years later. So that could be a little bit of an unknown.
Interesting. Did you have a way of figuring out whether they were adherent to CPAP? Or like, did you look at resupply or downloads or anything like that?
No, that's a good question. Uh, so we had a way of knowing for certain that CPAP was prescribed and that the veteran almost certainly took it home with them.
Mm.
But in terms of how often did they use it, what was their residual AHI, we are lacking all of that information. And so there could be a lot more
Mm.
nuance to it. Is it the CPAP itself, or maybe it's just something about the people who say yes to the doctor. They
Yeah,
say
yeah, yeah.
this is what you got to. Yeah.
The healthy outlier. Yeah, yeah, yeah. Yeah. So you start with 13 million patients. And then what? Like who got eliminated first?
We had the good fortune, the VA database is just so rich with
Mm.
a lot of data and a lot of people. And so we can be a little selective without losing so much in the way of statistical power. And that's really important, since PD is considered a somewhat rare outcome. And so a couple of things we wanted to do was we wanted to make sure that there was enough follow-up time so that we could draw meaningful conclusions. If somebody is, getting sleep apnea and then 2 months later is being diagnosed with Parkinson's disease, I don't feel confident that those are causally linked. That
Mm.
person may actually have had Parkinson's already,
Mm-hmm.
but they're just not getting seen and evaluated. And so we wanted there to be enough of a lag time.
Mm.
And then, of course, if they already had Parkinson's disease, then you just can't answer our question at all. So those were the two biggest things to eliminate. And if there's just a total lack of data, we can't make heads or tails of it. We don't want that contaminating things.
And so what did it go from 13 million to what?
I believe it was about 11 million.
I mean, that's a lot of records.
It is a lot, yeah.
And it sounds like some of it's kind of tedious and laborious.
Certainly we wanted to spend the effort on the manual validation, like I
Yeah.
talked about
Yeah.
earlier, so that when we did have, the computer doing a lot of that number crunching work, that we felt confident in what those results were going to be. If you look at other studies that have tried to examine this question, they are considerably smaller.
Mm.
50 times smaller, 70 times something
Oh, wow.
something like that. So that this was an advance.
Well, and I understand you adjusted for other factors like BMI, diabetes, depression, and hypersomnia. So did any of those matter?
Yeah, great. So we if you just look at people with Parkinson's and people without, or rather, if you look at people with sleep apnea and people without, there's going to be differences in those groups.
Okay.
And so we wanted to make sure we adjusted for the things that we picked a priori that we thought were critical. And so right off the bat, before in our first analysis was, hey, let's make sure that age is balanced, sex, race, smoking status, before getting any sort of meaningful result. And it turns out you do all of that, and we see our big effect. And then we can go deeper into some of those other factors that you mentioned, and so our result holds even if you adjust for those things, which is I think meaningful. One interesting signal that kind of came up is that it seems like women may have a much higher risk of PD from sleep apnea compared to male veterans.
Really?
Yeah, they had about a double the risk. And overall, women make up a smaller portion of the military, and it's about 10% in our sample. And so we've got much wider, confidence intervals here. So it'd be really interesting to look outside of the veteran population where the individuals are more balanced to see whether that replicates or not.
So why did you, I think I understand the other ones, but why smoking?
So, believe it or not, smoking has been shown again and again and again to be one of the most important protective factors against Parkinson's. So,
Hmm.
I often tell my patients, these are the things that we think are kind of important for our brain. Also, smoking is probably, good in terms of your Parkinson's risk, but don't start because we know it's got all these other problems.
So how does that work? I'm a pulmonologist and like this is hurting me to hear this.
Well, don't change your practice. Smoking is bad.
Like
Smoking is bad.
how does it protect your brain?
Well, it's unknown. So
Okay.
there's a few hypotheses that are out there. So it could have something to do with nicotine. So maybe some nicotinic receptor
Oh.
stimulation is modulating the dopamine system. Maybe it's doing something with neurotrophic factors and supporting key brain structures. Maybe it actually is got some sort of monoamine oxidase uh, inhibitory activity such
No
that
way.
you're kind of getting a little bit of a dopamine boost. But a favored one actually is that maybe this is some sort of reverse causation. So, people with Parkinson's disease, even in the prodromal state, there are definitely changes in mood and changes in personality. And you'll find that people with PD are often risk averse. And
Hmm.
so maybe it's people who smoke are just reward seeking people and they were just never going to develop Parkinson's anyway. Um,
Interesting.
so we haven't figured it out, but boy, are there a ton of studies out there that keep showing the same thing.
That's crazy to me. So, what about the sleepy people? So, one of the criticisms in our world when we look at CPAP and cardiovascular outcomes is that the research is done on non sleepy people with OSA because it's felt to be unethical to withhold CPAP from somebody who is sleepy with obstructive sleep apnea. And so, did you pull the sleepy people out, or were they included?
So we included on the first pass all people with sleep apnea, whether they
Okay.
were sleepy or not sleepy. In this database, we don't have granular data from scales like the
Okay.
Epworth scale. We do look at things like hypersomnia as a diagnostic code. And so we saw there was actually a little bit of an imbalance. So the people who were non CPAP users actually were sleepier by this measure than the CPAP users. But adjusting
Mm.
for that didn't influence the beneficial effect. So we still saw that 30% reduction. I will say too that within the VA, I since they don't have to follow necessarily really strict Medicare rules, I think they are able to kind of prescribe CPAP just because they think the patient needs it and not necessarily because they're checking all the boxes. The AHI is always going to be there, but some of those symptom things,
Mm.
even if they're not sleepy, but it still feels clinically like the right thing to do. I think veterans have an easier time getting access to it.
Well, I mean, that's nice to hear.
Yeah, I think the VA system does a number of things well.
So, what is the number needed to treat?
So we were able to calculate that. So the number needed to treat is a measure that also has a time component, and it's based on absolute risk reduction. And so in our study, a little more than uh, two fewer cases of Parkinson's disease were seen in that group with sleep apnea that used CPAP at the end of 5 years,
Mm.
compared to the non-users. And so you do some fairly simple arithmetic, and so our number would be a little over 400 people that would need to be treated with CPAP. And at the end of 5 years, one of those people who would have gotten PD shouldn't.
Mm.
So it depends on your perspective on things. That's kind of a large number, but when you're comparing that against, what are the harms of not treating, I view that as a pretty encouraging and positive finding.
Okay, that's fair. Because that was my initial thought. I'm like, that seems high, but that
It
makes
it's
sense.
object it's objectively high. But my lens is what is this doing on Parkinson's incidence? But you can teach me more about all the other things that sleep apnea is good for: cognition, stroke risk, all these other things. There's other reasons
Yeah,
to
that's
do
fair.
it.
You're right. Yeah, that's fair. That's fair. So, could you look at hypoxic burden? Like, was that ever factored in?
No, in this study, we did not
Okay.
look at that. I think there might be ways to get into that, but we just found that to be overly laborious to tease out.
So, let's take a short break. And when we come back, we'll talk more about obstructive sleep apnea and Parkinson's disease. You're listening to Talking Sleep from the American Academy of Sleep Medicine. Welcome back to Talking Sleep. We're talking with Dr. Lee Neilson, a movement disorder specialist, on the association between obstructive sleep apnea and Parkinson's disease. So, can we talk a little bit about RBD?
Sure, love to. What should we talk about?
So, the one thing I've kind of learned fairly recently in the last few years is that if I speak to a neurologist who takes care of RBD, a ton of their patients go on to develop neurodegenerative stuff. But if you speak to colleagues who work within a VA system, almost none of them do. So, is this sort of the difference between idiopathic RBD or trauma related RBD? Like, I don't understand this.
You're not alone in not understanding this. I don't think I fully understand the difference between those two entities. So maybe taking a step back, so idiopathic or isolated REM sleep behavior disorder, I think is pretty well established. It's linked to neurodegenerative disease, and in particular, the synucleinopathies. So that's largely going to be Parkinson's disease, but there will definitely be a large number that develop dementia with Lewy bodies, and a relatively smaller proportion that develop multiple system atrophy. And there's been, a number of really large cohorts, international cohorts, that have, followed people for 5, 10, 14 years. And, you look at some big meta-analyses, and there was one that I like to refer to from 2019 that says basically it's 96%. If you follow them for 14 years, they'll develop neurodegenerative disease. Current studies now are trying to refine that. So how does age, play a role? So if you're diagnosed with RBD at 55, that's probably more serious than being diagnosed at age 30. We haven't done a 50-year study yet.
Oh, interesting. Okay. I'm not sure I would have thought that.
Yeah, age seems to be extremely important. And then there's going to be some other things out there too that can kind of further refine risk. Now, this trauma-associated sleep disorder, I don't know if that is fully established by the field as an accepted diagnosis. My understanding is that there's still that dream enactment component, there's still that REM sleep without atonia, but there's all this hyperarousal and other autonomic symptoms that are going along with it. And so there's this question of, well, if that is really driven by PTSD or kind of another pathophysiologic process, does that mean they have the same risk of developing a synuclein-based disease? And I think you could make the argument for both sides of that. I guess my approach would be, yes, I think there's a little uncertainty, but you're probably at high risk. And what's the harm in counseling them on, good sleep and exercise and things like that are good for our brains?
Yeah, I mean, that's fair. Because I also feel like I struggle with women who have dream enactment behaviors and then they have REM sleep without atonia, because I'm not sure that we have robust data on the trajectory of a woman with RBD.
Right. I think some of that is you'll start to see some of that coming out in the next few years for sure.
Because I always kind of wonder, I'm like, is this a separate thing? Like, is the underlying pathological change different? Like, do they just kind of act the same, but they're actually two totally different things?
Yeah, that's great. And now that there's, newer diagnostic tests or more available diagnostic tests, will be able to kind of figure that out. So what's happening to their, dopamine system on PET or SPECT imaging? Can you identify synuclein in skin biopsies between those groups? And so given enough time, I think we'll figure it out.
Okay, so tell me about the skin biopsy. I've been fascinated by this. I think I learned about it a few years ago. And I don't think we have anyone that does it locally, but is this part of the protocol?
The protocol for
diagnosing PD?
It is a clinical tool that can kind of supplement our diagnosis. So personally, I use it very minimally.
Oh, okay.
PD is a clinical diagnosis. If you've got, 2 of 3, rigidity, rest tremor, bradykinesia, if I'm looking at some of these other non-motor features, hey, your sense of smell is not that great, maybe you've got a little bit of lightheadedness, then I'm thinking this is probably PD. Now, certainly there are some cases that are more challenging than that. That's the real world as we're dealing with these diagnostic conundrums. And so, hey, I want to call it Parkinson's, but you're on a dopamine blocking medication, or you've had essential tremor for a long time, and now things are a little bit different. And so there may be a role for the skin biopsy there.
Okay, that's interesting, because some of the factors that you identified, like the anosmia, I don't think you said constipation, but constipation was one that somebody had brought up before, that if you have sort of these three elements, and I think the third was orthostasis, that those sort of select out the people that are most likely to convert.
Yeah, absolutely. With probably hyposmia being the biggest one. So that changes about 8 years, 7, 8 years uh, before PD diagnosis.
Oh, that long.
Constipation
Yeah.
could be as much as 20 years. So it is really a long prodromal period, but just the odds ratios are much lower. You see a lot of constipation in older people for various reasons.
I wondered. So then, yeah. So then what about the person that has, like you said the benign essential tremor, right? And then it sort of becomes more, maybe they develop some gait instability or whatever. Is it that it was initially an early, like the tremor was from Parkinson's? Or was it truly this benign essential tremor and then this new process?
Yeah, we're now really diving into some complex topics here. uh, so one comment to make is that we have just dropped the term benign
Oh,
because
okay. Good to know.
as patients have constantly tell us, there's nothing benign about this. I can't hold a cup. I can't feed myself
Oh.
soup. Like that's a big deal. It won't kill me, but but it is a big
Mm,
deal.
that's fair.
Um,
I like that. Okay, noted.
yeah, so just essential tremor. It's not uncommon that we see people with essential tremor for 10, 15, 20 years, and then later on they're developing some Parkinsonian features. Sometimes that's just the way the disease is progressing. So we're also recognizing not only is it a big problem, a big impact on their quality of life, but it is a progressive degenerative disease.
Mm.
There are cognitive aspects, there are balance aspects, and the tremor can kind of shift. It's not just an action tremor. You might see some rest component to it as well. And so we're learning more about that. That being said, there is probably a true signal that people with ET have a true higher risk of developing Parkinson's disease, and so they're likely two uh, distinct entities that just happen to occur in higher rates in
Interesting.
those people.
So ET meaning essential tremor. Okay.
Yeah.
You know what one of my friends taught me? I have a patient with, RBD, and he's developed Parkinson's, and he's got this really bad tremor. And it was hard for him to put on his CPAP mask. And so I like texted a neurologist, phone a friend, my neurologist friend, and she recommended weighted gloves.
Mm.
And I think it helped him to like help with the tremor so he could put his mask on at night.
Yeah, I really like those clever
Yeah.
tricks, and oftentimes I'm learning from patients themselves, because you just need it for that moment of putting the mask on. You don't
Mm-hmm.
need to take a pill 4 hours before and deal with the side effects and
Yeah,
things
that's
like
fair.
that. So oftentimes, if occupational therapy, I think those people are quite clever and creative, and they're
Mm.
very task focused.
Okay.
They say, hey, if you're having trouble with your CPAP mask, let's bring that in and let's see what strategies we can kind of come up with together to solve that problem. Or I'll often just tell people, hey, just go to your local sporting goods store. They've got weighted gloves. Just like put one on and see
Mm.
see what it does. More often than not, it helps somewhat, but is it enough for them to buy them? That's kind of up to them.
Well, I just love that idea of thinking outside of the pharmacy. And it was like $22 on Amazon. It was like not a big intervention, but it really did help significantly.
And with no subscription, no no refills. Yeah, that's huge.
Yeah, that is huge. So I'm sitting here trying to digest all of this really cool information. And I have to kind of come back to when you talked about, you looked at mild sleep apnea, you looked at severe sleep apnea, and then you looked at CPAP as a treatment modality. Is there a way to pull out also people who maybe have Inspire or oral appliance or some other way of treating their sleep apnea?
Totally doable.
Okay,
Just not something that we did.
gotcha.
So we found there was one large nationwide study, I believe, out of Korea that looked specifically at the upper airway surgery,
Okay.
showing that there did seem to be a protective effect there. But it's just not done in such high rates in the VA system, so we weren't going to get a meaningful answer.
Mm.
Same thing with the oral appliances. We couldn't capture that very well. And then the hypoglossal nerve stimulators, anecdotally, I am seeing a ton of veterans who are getting these things
Mm.
implanted, but they're just so new. So I
Mm.
think we'll need to maybe go back 5 years from now and look at that specifically, because that could help a little bit with, what is it that you're fixing, and is it having the same effect? That'd be kind of interesting.
That is interesting. And then now, right, tirzepatide was FDA approved for moderate to severe sleep apnea. And then, right, like I just feel like there's going to be a lot more factors. And then we're hoping for what, 2 or 3 medications for sleep apnea in the next year or two.
Yeah, yeah. So this is kind of exciting how this is growing, and it makes things complicated in some sense, but also, exciting for
Yeah.
our field.
Yeah. So is there anything that we have missed?
The one thing that I would like to add
Yeah.
is that, we're talking about these reasonable numbers, this 30% reduction in Parkinson's disease, but that still means that people doing everything right are going to develop PD, a good chunk of them.
Mm.
And so the last thing that we actually did with this study was to figure out, okay, what about just those people that ended up getting PD, but they were great about wearing their CPAP? Was there anything different about their Parkinson's course, about their trajectory?
Yeah.
And it turns out that maybe they have a little bit more of a benign course.
Huh.
So we could look at things like falls, we could look at things like fractures, we could look at mortality, and all of those were better off. And so I think that's kind of another pearl to kind of take away. Hey, don't throw your mask away just because you got your sleep apnea. It may still be doing something.
So that's a really important message, though, right? It's not that, oh, too bad if you don't fall under that 30% of improvement, but there is potentially other, meaningful improvement that you can receive by treating your sleep apnea.
Yeah, it'd be great to kind of validate that more
Mm-hmm.
in a prospective kind of way. Again, we're just looking at codes for these things, but it was a biologically plausible signal, and so I think it was worth following up on.
Yeah, no, it was interesting. I think that's how I found you, is I found your article. Then I was like, well, this is pretty cool. Like, how impactful is that, right?
Yeah.
Yeah. So is there anything else that we should take away from this work?
I don't want to in any way criticize my own work, but I do think it's important to recognize, I think these are important findings. I do trust the rigor that we went through to report this data, but it is an observational study. It is limited to veterans, which are a
Mm.
largely male, largely Caucasian, sort of population. And so thinking about who does this data apply to, I'd like to think that it is more broadly applicable, but not necessarily. But certainly if you're dealing with veterans at all, I think this is a really important thing to kind of be bringing up with them, and pushing, hey, we have these strategies to address your sleep apnea. They can do a number of things already, but maybe they can also have an influence on, neurodegenerative risk.
Mm. Well, thank you for joining us today. It was super helpful to think about how sleep disorders may be a modifiable risk factor for the onset of dementia, and kind of, for me, really validating that the work that we do really matters to our patients and their families. So I appreciate you being here and sharing your wisdom with our sleep medicine colleagues.
Thanks for having me.
Thanks for listening to Talking Sleep, brought to you by the American Academy of Sleep Medicine. For more podcast episodes, please visit our website at aasm.org. You can also subscribe through your favorite podcast service. And if you enjoyed this episode, please take a moment to leave a rating or review. For more feedback or suggestions, email us at podcast@aasm.org. I hope you'll join us again for more Talking Sleep. Until next time, this is Seema Khosla, encouraging you to sleep well so you can live well.